Okay. So, as I was saying, when aldosterone binds, maybe when the zona what glomerulosa produces what aldosterone will diffuse through the basolateral membranes and enter into the cell. When aldosterone goes into the cell, they bind to the aldosterone receptors, and that will activate the DNA binding domain, and it will translocate itself into the nucleus. And when the DNA binding domain translocates itself into the nucleus, what happens? It causes the production of messenger RNA. And messenger RNA will come and lead to the production of different kinds of protein. One is what the aldosterone-induced protein. And we said when the aldosterone-induced protein are produced, they are going to perform some 6 functions. One is what activating inactive sodium channel, insertion of sodium channel from the cytoplasm or the cytosol, and also was synthesizing sodium channels. Then at the basolateral membrane, we are going to synthesize sodium potassium ATPase pump. We are going to insert sodium potassium ATPase pump, and we are going to activate inactive sodium potassium ATPase pump. All right. So that's what he said. So now when you give aldosterone to a person, what happens? The aldosterone will go and bind to the aldosterone binding site. So the drug, the spironolactone, will go and bind to the aldosterone binding site. So when aldosterone comes into the cell, that binding site has been blocked. So aldosterone cannot bind to its receptors. And if aldosterone does not bind to its receptors, we are not going to activate the DNA binding domain. And if you don't activate the DNA binding domain, then we are not going to produce messenger RNA. And when messenger RNAs are not produced, then we are not going to synthesize aldosterone-induced protein. And that will affect synthesis of sodium channels and other insertion of sodium channels and activating sodium channels. So when we block aldosterone from its receptors, we are not going to synthesize sodium channels. We are also not going to produce or synthesize sodium channels or insert sodium channels or activate sodium channels. We are also not going to synthesize sodium potassium ATPase pump. We are also not going to insert sodium potassium ATPase pump at the basolateral membrane, and we are also not going to activate sodium potassium ATPase pump. So when that happens, that means that the number of sodium channels on the luminal side of the basolateral membrane will be reduced. Okay. And when the sodium channels are reduced and you don't have much sodium going in, because the more sodium goes into the cell, it enhances the effectiveness of this sodium potassium ATPase pump. But if the sodium going in is less, then we are not going to bring in much potassium into the cell. And when the potassium coming into the cell is less, then we are going to lose less potassium. Okay. So the potassium sparing diuretics help the body to retain potassium. And when we are retaining potassium, we are losing sodium. Then the next thing about this agent is that the potassium sparing diuretics, the spironolactone, they act in the presence of aldosterone. So some people say they act when aldosterone is present. So in the presence of aldosterone, they act. And we can use this drug to manage edema, but the main use is that we sometimes add this drug to other diuretics to prevent loss of sodium, to prevent loss of sodium, to prevent loss of potassium. Are you okay? Most of the diuretics will lead to loss of potassium, but this diuretic will help the body to retain potassium. And with the triamterene and amiloride, these drugs do not bind to the aldosterone receptors. If I am permitted to say this, the spironolactone is made of steroids. So let's say they are steroidal. So they can diffuse and enter into the cell, go into the DNA, and cause what we talked about. The triamterene and amiloride are non-steroidal. So with them, they don't bind to the aldosterone receptors, but they are rather going to block the sodium channels. So that means that aldosterone can go into the cell, synthesize all the sodium channels that they want to synthesize. Maybe cause all the insertion that they want to insert. But what this drug will do is that after aldosterone has produced all these sodium channels, they will come and block the sodium channels. So sodium does not go in. If sodium is not going in, what is happening? We are also not bringing in what? Potassium. So if you are not bringing in potassium, we are what? Reserving what? Potassium. So the amiloride and transferrin do not block the aldosterone receptors. They block the sodium channels that aldosterone might insert at the what? Luminal side. And when we don't have sodium going in, we are not going to what? Bring in what? Potassium. So potassium stays in the blood, and that can lead to what we call what? Hyperkalemia. So one side effect of this agent that I have talked about is what? Hyperkalemia. Hyperkalemia. So we can use the potassium-sparing diuretics, especially the spironolactone, to manage conditions such as hypertension, ascites. We can use this to also treat what we call hypokalemia. If a patient is having low potassium levels and you want to elevate their potassium levels, then we should be thinking of what? Giving what? A potassium-sparing diuretic. So we can use this agent to also manage what? Hypokalemia. One side effect of the potassium-sparing diuretics, especially the spironolactone, aside hyperkalemia, has to do with gynecomastia, like male developing breast. So it's one side effect of this agent. But as I said, we can use this agent to manage liver cirrhosis and other conditions. So that will be it for the potassium-sparing diuretics. If you have any questions, you can drop it in the comment section, and it will be what? Attended to. So our next group of drugs that I will be talking about will be the osmotic diuretics, and that will end our lecture on diuretics. Thank you.